Invisible.
Thank you. Thanks to IJPP team for inviting me to give a talk. First, as I'm going to talk about cranial ultrasound, it's important to say that I'm not a radiologist, but I'm a neonatologist who's interested in work that imaging as well. So why we do ultrasound in newborn is to diagnostic purposes, as well as the prognostic purposes, so that we can predict outcome and counsel parents and do some early intervention. My objectives are just to tell about how we can prepare for a good ultrasound and what are the standard views and what are the common abnormalities that you see in ultrasound. Preparation is very, very important. We don't want to disturb a very sick baby. Usually they are in the NICU. So it's important to check with the nurse and the parents and the baby as well, make sure the baby is fine. And the infection control is a key thing in NICU. So make sure that you clean your probe and hands and wash your hands and things. And then also have a paper towel so that you don't spread the gel everywhere. And you clean the probe using ideal antiseptic measures. It may be they are recommended by the machine companies, and use generous amount of gel to have a good medium. And also you have to be in a comfortable position as well as the baby so that you can get a good picture. It is important to use the correct probe. The frequency of the probe varies from 3 to 8. Usually 5 would be ideal to look at the superficial and deep brain structures. And then usually we do the scan from anterior fontanelle, which is very easy to identify. And in terms of machine, it's important to adjust the gain, brightness, and depth, and also label the name of the baby. So the windows that we have in the skull, there are various, but commonly the scan is done at the anterior fontanelle. That is a one which gives a maximum view of the brain, but it is also important to look at temporal and mastoid view, which gives a special access to midbrain and cerebellum. And posterior fossa, sometimes we do as well, but that is very difficult to do. So in the anterior fontanelle, what are the sections we do is a coronal and sagittal section. And in the coronal, at least 6 images going from the front to back. We'll go through one by one. This is the front where we see the normal brain structures. In the front is intermediate fissure, frontal lobes, and then the orbital ridge. As you go back slowly with the coronal pictures, one of the things about coronal pictures is you should hold the probe where the marker is on the right side so that it's already marked on the right. So you could see as you go back in the coronal pictures, you can see the lateral ventricles, Cavum, Septum, Pellucidum, and choroid nucleus, and you can see the temporal horn as well. And as you go back, you can see the clear double-layered corpus callosum now, and both the lateral ventricles and also third ventricle at this stage, and thalamus as well as the hippocampus as well. And you go back, you see the posterior horn of the lateral ventricle where there is a choroid plexus, and also this is the area where we see the periventricular white matter where there can be abnormalities, which is to be identified. And this is a normal periventricular matter you can see at this point, and then you can see the interhemispheric fissure as well. And further back, we'll give you the clear picture of the white matter, which is a periventricular at the level of parietal cortex. It is also an important area in preterm infants where you can see the periventricular loop malicious. That is a coronal view we saw, and now sagittal view. Sagittal view is a midline sagittal view and then 2 parasagittal views on both sides. So that will be 5 views that you would be taking. In the sagittal view, the marker will be in the front, as in the right for the coronal views. So in the sagittal view, in the midline is very important. You see double-layered corpus callosum with the cavum, septum, pellucidum, the darkness, and then the guitar-shaped one. When you get the guitar shape, you are sure that you are in the midline view, and that is the cerebellum forming the guitar-shaped view. In front of the cerebellum is the 4th ventricle, and then the pons and midbrain comes in there. As you go on the sideways with the parasagittal view, this is one of the important view where we see the caudate and the thalamus. And then you can at the caudothalamic groove is you have the germinal matrix. So if you have a IVH, that is where the first start to come. And then you can see the choroid plexus, the bright area, and then the lateral ventricle. And as you go back, as you go further on the sagittal region, there you see the periventricular white matter area and then the Sylvian fissure. So these are the normal views of the coronal and sagittal scans, and there will be Doppler studies that we can do, which helps us to assess the cerebral blood flow And if there is any vascular abnormalities also, it helps to pick it up. And we calculate usually the index called a resistance index, and which is a normal value is 0.6 to 0.9. I'll talk about the abnormal ones later on. This is the midline sagittal view, where if you put the color on, you get the flow of the anterior cerebral artery there with the arrow pointed out, and that's where we put the pulsed wave marker, and then you get a good systolic and diastolic flow like this, and then you can measure with the peak of the systolic and then the end of the diastolic point. That will give you the RA. Here the RA is 0.75, which is a normal one. One of the normal things that you see is the choroid plexus cyst that can be a normal feature. You can see the cyst in the choroid plexus. We don't have to worry. But if there are multiple choroid plexus cysts, you might have to think about whether there is any genetic abnormalities in the baby. And this is a Cavum septum pellucidum, which is a normal thing between the frontal horn of lateral ventricle, which is usually open in the preterm infants, but they usually closes soon after birth as a term baby. This is another cavum, which is called the Cavum septum vergae, which is just posterior to the Cavum septum pellucidum. And this is also usually open in the preterm infants, but it closes in the term babies soon after birth. The Cavum veli interposta is again posterior to the Cavum septum vergae. It's posterior to the corticogeminal plate of system next to the pineal gland. It's only seen in very premature infants. It's also very benign conditions, nothing to worry. Sometimes you can see congenital cysts. Congenital cysts are like this. It's next to the lateral ventricle. You can see in the coronal and the sagittal section. It should not be mistaken for any periventricular cystic area or a white matter abnormality. So it is important to know about congenital cyst. So what are the abnormalities that we see in the ultrasound? So the common injuries, first we see, if we see in preterm babies, are IVH, white matter injury, and the cerebellum hemorrhages. Cerebellar hemorrhages are not often easy to diagnose, so sometimes you have to go to the mastoid view to diagnose that. So in a preterm babies in NICU, those who are less than 32 weeks, all of them should have an ultrasound scan. And the rough guideline is this. So you should do it within as soon as after birth. On day 1, it's important to rule out any IVH or having to document that there's a basic normal scan. And then day 3 and then day 7, if there's any progression or any if there's to rule out IVH again. And then again 32 weeks and 36 weeks. These are the minimum 5 scans in the NICU for all babies we should be doing. But if there is any stage the scan is abnormal with IVH or white matter injury, we may need to monitor more frequently for the ventricular measurements or monitoring of the lesions in the white matter. So what is IVH and its interventricular hemorrhage? We all know. How do we classify them? We have 4 grades. We used to say them grade 1, 2, 3, 4. And the grade 1 is germinal matrix hemorrhage, where it is just on the germinal matrix. Grade 2 is germinal matrix and IVH, but less than 50% of the ventricle filled with blood. If it is more than 50%, it's grade 3 with or without ventricular dilatation. If there's a parenchymal involvement, that will be grade 4. So this is the grade 1. This is a cardothalamic groove, as I said, and this is where the germinal matrix is there. And this is bright, that is abnormal. So it is seen both in the sagittal and the coronal section. That is called germinal matrix hemorrhage or grade 1. And how do you identify blood in the ultrasound is, if this is as bright as choroid plexus or the bone, usually that is the abnormality that you would say. And in grade 2, you can see this is gone into the ventricle and it's less than 50% of the ventricle. So that is grade 2. And if it's grade 3 is with or without ventricular dilation, if it is more than 50% of the ventricle covered with the blood. And grade 4 is the parenchymal involvement, which is called periventricular hemorrhagic infarction. And you can see there's a large hemorrhage here in the grade 4 with the bottom scans, and it's also affecting the parenchyma of the brain. In those babies with particularly the grade 3 and grade 4, it is important to measure the ventricle frequently because there can be a post-hemorrhagic hydrocephalus that you would come across in these babies. And it's important to see the VI is the ventricular index, where you measure the maximum dilated ventricle from the midline and at the level of the interventricular foramen of Monroe. And you can measure the anterior horn width of the lateral ventricle. And then you can also measure the thalamo-occipital distance. And we have a standard values for this and when they are abnormal as well. So particularly this is a Levene's chart, ventricular index chart. This is where we plot with the ventricular index 97 centile, as well as this is a 4 millimeter above the 97 centile. So when we plot the ventricular index, we monitor based on the gestational age in the x-axis, and then we intervene when it is 4 millimeter above 97 centile, or if there is any clinical symptoms like sunsetting of sign, bradycardias, apneas in the babies that we see, and we do intervention with the lumbar punctures, ventricular taps, or ventricular reservoirs at in NICU. The other common problems that we come across in preterm infants is the white matter injuries, and you can see sometimes brightness next to the posterior horn or next to the sagittal but just to slide, some brightness is not abnormal, but if it is very bright, as bright as the choroid plexus or the bone, then that is PVL, periventricular leukomalacia, probably grade 1. It can turn into a cyst if it is cyst only in the parietal region, that you can see 1 or 2 cysts, that is grade 2. But if you see a lot of cysts like this extending to frontal, parietal, probably occipital region as well, that is grade 3. And if it extends to subcortical regions, white matters, that will be grade 4. And babies with the PVL of grade 4 and grade 3, they are more likely to have around 70 to 80% of them will have CP or they die. So it's very important to prognosticate based on the ultrasound, and maybe sometimes in some cases we would have to do MRI at term gestation to get more information as well. And if they are really unwell, it is important to talk to the parents and see whether is it worth to continue the intensive care for these babies. And there are some more in term babies. In term babies, we do scans in HIEs and to rule out any congenital brain abnormalities, and some congenital infections can be seen, obviously, in the ultrasound. And you can also document some brain injuries from the metabolic things like hypoglycemia, kernicterus, and any other metabolics as well. So I'll show you some of them. Again, it's a normal scan in term brain MRI, similar to what we saw in the preterm babies. So you can see the lateral ventricles. Usually Cavum, Septum, Pellucidum is closed, and then this is the thalamus, cerebellum, and midbrain, and yeah, that's the thing. And in acute phase of HIE, what you would see is the cerebral edema. And if you see on day 1, this is a normal scan on the left, where you can see the gray and white matter differentiation with the sulci and gyri. But on the right, you can see there is no clear-cut definition of a Sylvian fissure or a ventricle or a thalamus or even the interhemispheric fissure. So that is because of cerebral edema, so that you can diagnose very easily and you can say that there's some brain injuries going on. In terms of acute to subacute phase, you can see early on there are some changes which is not very obvious, but if you see the late changes, which is on the bottom line, there are a lot of brightness and echogenicities in the deep gray matter, particularly the thalamus and caudate nucleus. So that can be diagnosed around 3 to 5 days after the injury, sometimes up to 7 days. But these are very obvious in the MRI, but ultrasound can help diagnosing them. As I mentioned, Doppler is a key thing in HIE babies, the hypoxic ischemic encephalopathy babies. And when you do Doppler and measure the resistive index, when it is less than 0.55 or 0.6, it is correlates with the adverse outcome in the long term. And this is from the Levene's study almost 30 years ago now. And that showed us if you do RI within usually the 24 to 48 hours of birth or of the insult, which happens around the time of birth, and that indicates that having a low RI indicates that there is a reperfusion brain injury is happening, and that would indirectly correlates with the long-term poor outcome in these babies. Now that we cooled all these HIEs, the predictive value is not the same, but it is really useful investigation. When do we do for term babies? So it's usually better to do in HIEs soon after admission, and then do another one in 24 to 48 hours, and then day 3 to 5 to see the pathologies, how they evolve and develop. The last few important things like a CMV infection that you can diagnose in cranial ultrasound itself. So when you have a babies with the IUGR, microcephaly, petechial rashes, hepatosplenomegaly, if you suspect congenital or postnatal CMV infection, before you can send the urine or blood for CMV PCRs, you can put a probe in and diagnose. You can see in some babies the lenticulostriate vasculopathy in the deep gray matter. So the vessels are very prominent and calcified here. That is very obvious here. And then you can also see in some babies with the CMV infection, the subependymal pseudocyst. And if it is multiple and bilateral, you should always screen for a torch infection. So that would be one of the sign of torch infection. Just quickly a word about other views. It's always easy to do anterior fontanel views, and because you get more information from them. But in specific cases like if there's a cerebellar hemorrhage, or you want to look at the cerebellum here, and this is the mastoid view, you can do axial and coronal in the mastoid and the posterior part of the ear, and you can get more information on the temporal lobe, pons, and cerebellum here. So this is one of the cerebellar hemorrhage which we saw in the mastoid view, which was not picked up in the anterior fontanel view. So with the training, we can also do the mastoid view. The other one is temporal view. Temporal view is just 1 centimeter above and anterior to external auditory meatus, and you can see the probe is facing the front. And this shows a lot of information in terms of midbrain and the middle cerebral artery when you put the Doppler on. So sometimes in the stroke, middle cerebral artery flow may be disturbed, and this will be really useful to highlight there. So commonly what mistakes we can happen when we do the ultrasound, probe can sometimes slip off anterior fontanel. So it's important to keep the probe persistently in the same place and adjust the direction rather than moving the probe. And so a gel may be insufficient, so you don't get a good picture. So it's important to put an adequate amount of gel. And angling is important to see the flow of where the brain is, which level we are taking the pictures and important things. There can be sometimes drop out because of the small fontanel, so you can adjust the probe accordingly with the smaller curvilinear or a linear probes. And images can be too dark or too bright, so you have to adjust the gain properly. So otherwise, sometimes if you don't adjust the gain, there are a lot of bright areas which can look abnormal, but eventually it was normal. So it's important to adjust that. So in summary, ultrasound is a very useful bedside investigation, and it can be easily trained. All the trainees in neonatologists are trained to do a basic ultrasound to pick up in a IVH or a white matter injury, or in HIEs, Dopplers. And it's very easy to kind of prognosticate based on that. And it gives a lot of useful information in there, and it is must for all NICUs. Thank you.
Thank you so much, sir, for that informative talk. May I now invite the next speaker, Dr. N.C. Gauri Shankar, pediatric